Fort Riley. Welcome to the emergency room at Irwin Army Community Hospital. Today, our goal in this video is to help you understand how the emergency process works from the time that you walk into the sliding doors all the way till you get discharged. And Larry Couchman here is the Chief of Emergency Nursing. He's going to be our guide throughout this journey.
Good day, and hopefully this is your first visit to the emergency department. And because of that, we're going to give you some insider tips and kind of demystify the process of emergency services. So our first step today will be going over to rapid triage or our first look nurse.
Okay, Larry. So the patient will come in and present at this desk. What happens?
Well, this desk is where our first look or our rapid triage takes place. So over a 1 to 2 minute process, we'll have a quick assessment by a nurse, and then it'll be determined of 1 of 3 things. It's a life-threatening emergency, they'll go immediately back. It's a situation that could turn life-threatening, or 3, it's a non-urgent situation. And after that, then we will go ahead and proceed getting some basic demographics to set up a chart.
I noticed from the 3 things that you mentioned, or the 3 categories, is that there's nothing there like for routine care, say cold, sniffles, a headache, maybe some sinus pressure. Is it appropriate for a patient who's experiencing those things to come and present here?
Well, the emergency room is not the most appropriate place for something like that. The most appropriate place would be your primary care provider through an appointment. Yes, we will see a routine type care or a non-urgent type situation, but again, we see patients based on their condition they present and what's the most serious. So a life-threatening situation is going to occur first, and they may come in last, could be the first seen. So a person that presents with a cold-like symptoms may have to end up waiting for quite a period of time.
Okay, so let's go to the triage room and see what happens there.
Exactly.
Okay, Larry, we are now in the triage room. How long will it be before I get to this point?
Well, that's situational. It could be 2 minutes, it could be 15 minutes. It kind of depends on the census and what other patients are out there.
Okay, so when I'm brought here, what can I expect to happen?
Well, a little bit more detailed assessment. We're going to get a little more into your history. We're going to get a problem-focused survey. So if you're saying you may be having shortness of breath, we're going to do a much more detailed assessment of that situation. Okay. And then we're going to do a full set of vital signs.
Okay. And then you might end up telling me to go and have a seat before I am brought back to a bed. But what if I'm having some kind of pain or discomfort? You send me back there, I'm going to feel like you're not taking me serious.
Well, actually, no. Here in comprehensive triage, we have a set of protocols that we can initiate. We can do over-the-counter medications such as Tylenol, ibuprofen for pain. We can administer medications for fever if it makes within certain parameters. We can order a urine sample. We can order lab work, or we can even order an x-ray of an ankle or so, and have that all be working in the background while you're waiting until we can get a bed available.
Okay, well, let's go check out that bed and see what happens. Okay. Okay, Larry, we are walking into the treatment area, or sometimes referred to as an exam bed. Tell me what happens when a patient comes in here.
Well, you're going to be involved with your healthcare team, which consists of a medic, a nurse, and your provider, a physician or physician assistant. So, but also you as a patient, you are an equal partner in your care. So we really got to establish a great dialogue. So you're going to have further in-depth detailed assessment, especially if it was a private of nature type chief complaint. We'll get into that a little bit more. Your physician will be doing a much more detailed interview, and then a problem focus or a full body assessment.
Okay. This whiteboard, tell me what this is all about.
Well, after all that assessment and determination, we're going to start determining what diagnosis is in. This board kind of tells you the provider, the nurse, the medic, but also if the provider chooses to order some lab work, x-ray, or complex radiology work, kind of gives you an anticipation of time, such as x-ray and labs. We can expect about a 60-minute turnaround from the time of the test to the results are resulted for the physician to see. Okay. But if we get into some complex radiology, such as ultrasound or CT, again, it takes a little longer on the test, but to be read then by a radiologist is up to 2 hours. So one can anticipate if those are part of your order set, probably at least a 2-hour visit.
Okay, so if I have to have a CT performed on me, 2 hours go by, a half hour goes by, so now I'm close to kind of 3 hours from the time that I had that CT test. I'm starting to get frustrated, like I've been forgotten. Is that what happened? Did I get forgotten?
Well, I hope not. First of all, I hope we've been rounding and been communicating what the process is, but could have easily got distracted. We see at one time during high census 12 to 15 patients, so our healthcare team is managing that number of patients. So ask a question. What's the status? If we haven't been in to tell you, feel free to ask. But the other thing could be is, our major resuscitation rooms are on the opposite side of the department, so maybe we've had something that's come in by EMS or right next to the ambulance entrance, which is not visible to our primary care beds. So we may be involved in a significant trauma, training accident, or medical resuscitation, which has pulled resources away.
Okay, so that aside, the provider comes in after my lab results or whatever tests have been conducted. What will happen then?
Plan of care.
Okay.
So after, he or she'll come up with a diagnosis, a plan of care. So they'll be discussing that plan of care. Is that a discharge to home with follow-up? Is that a potential admission to IAC? Maybe it will require a transfer, and depending on the type of issue, we transfer to 3 primary areas. Topeka's, Manhattan or Topeka is a principal one for medical things. Major trauma usually goes to Topeka, Kansas City, or Wichita.
Okay, so let's talk about discharge. By the time everything has been said and done and I get discharged, what's my responsibility as a patient before I go home?
If we haven't addressed all your issues that you need us to address, and again, I want to caution that we're an emergency room, so we're not going to be here to take care of long-term healthcare issues. We're to take care of the acute issues, but if we're hoping to take care of those acute issues. So part of that discharge is we're going to be providing you a medication list. So after the meds that you gave us on the front end in comprehensive triage, we're going to be looking at what meds the doctor may have been adding, so you all have an understanding what medications you're going home on. You're going to have an understanding what is your follow-up, and then we're going to give you some education. Let's say you were diagnosed with pneumonia. We're going to have an education packet on pneumonia, which will give you home care instructions, but also give you a couple key points that requires a physician follow-up or even requires them to return to the emergency department.
Okay,
My last tip is we want the patient to be very engaged in their care. And if they're engaged in the care and they're equally involved in communicating with the healthcare team, then there's going to be a successful visit.
So what I hear you saying is that as a patient, I'm not just a passive recipient of everything that just happens to me.
You're a 50% partner in the interactions.
Great, thanks,
Thank
Larry.
you.